Thank you, Chip, and I'd like to thank the program committee for the opportunity to participate in this educational session and discuss the management of the axilla after neoadjuvant chemotherapy with the title, Refining Axillary Management After Neoadjuvant Chemotherapy, What Does the Evidence Support? These are my disclosures. So as we already heard, the surgical management of the axilla in patients with operable breast cancer has undergone significant evolution during the past 30 years. Axillary lymph node dissection was established as the undisputed standard of care by the end of the 19th century, and it remained so for the better part of the 20th century until trials such as the NSABP B04 showed us, as Dr. Wong showed us, showed no survival difference when elective axillary dissection was performed in clinically non-negative patients. However, following the disclosure of the results of the B04 trial, as Dr. Wong mentioned as well, axillary dissection still remained the standard of care at the time, and for various reasons, including that it provides good local control of the disease in the axilla, provides staging information and estimation of the risk of recurrence, and assists us with selecting optimal systemic therapy, which of course is a diminishing role with increasing use of genomic profiling and the use of neoadjuvant chemotherapy. And we believe that sentinel lymph node biopsy can provide most of the above, obviously with considerably less morbidity. So as Dr. Wong discussed, there has been a roadmap for decreasing the role of axillary lymph node dissection in patients with early-stage breast cancer without affecting the long-term outcomes. And safely, we have eliminated axillary lymph node dissection for clinical N0 patients with negative sentinel lymph nodes. We have diminished the use of axillary lymph node dissection in clinical N0 patients with positive sentinel nodes, as you already saw in the previous presentation. And we have demonstrated equivalent outcomes with less morbidity with axillary radiotherapy versus completion axillary lymph node dissection in clinical N0 patients that have a positive sentinel lymph node or sentinel lymph nodes. And what we'll focus today on this presentation is the potential for diminishing the use of axillary lymph node dissection in patients with either subclinically or clinically involved axilla with or without histologic confirmation with the use of neoadjuvant chemotherapy. Now we know that neoadjuvant chemotherapy not only affects the disease in the breast, but also downstages the disease in the axilla. In early randomized clinical trials that you see here, such as the NSABP B18, the EORTC trial, the ECTO trial, or the NSABP B27, we realized that neoadjuvant chemotherapy can downstage the disease in the axilla by 30 to 40%. These were the chemotherapy that we used at the time, either anthracycline-based or anthracycline and taxane-based. And of course, the potential for decreasing the extent of axillary surgery existed when sentinel lymph node biopsy was invented and became used. Previous to that, even if we would downstage the disease in the axilla, axillary lymph node dissection was still the procedure that we were performing. And of course, over the past several years, we've seen an increase in the rates of pathologic complete response, both in the breast as well as in the axilla, with the development of more active neoadjuvant chemotherapy regimens. So we went from rates of single digits with CMF to doubling that with anthracyclines, doubling that again with the taxanes, and then particularly in HER2-positive patients as well as in triple-negative patients, we saw a lot more activity for HER2-positive patients with the introduction of anti-HER therapy, either single or dual anti-HER regimens. And for triple-negative breast cancer, the introduction of carboplatin to the anthracycline taxane neoadjuvant therapy, and also the addition of checkpoint inhibitors as of recent, showed us the pathologic response rates can be up to 55–65%, similar to the ones that we see with HER2-positive disease. So clearly, that provides us with a tremendous opportunity to downstage involved axillary nodes and possibly minimize the extent of surgery after neoadjuvant chemotherapy. When we started to think about that, though, there were two theoretical concerns where we applied the sentinel lymph node biopsy concept in patients who received neoadjuvant chemotherapy. The first concern was what I call the anatomic concern, and that is that tumor involvement in the sentinel nodes and then scarring from tumor regression may alter the drainage pathway to healthy non-sentinel nodes who then become sentinel lymph nodes. The biologic component was the tumor regression after neoadjuvant chemotherapy may be different in sentinel lymph nodes versus non-sentinel lymph nodes. For example, tumors may regress in the sentinel node, but then still be present in non-sentinel nodes. And I suggest to you that if either of these is true, then sentinel lymph node biopsy false negative rate would be increased. So let's see if that actually is the case. Now, it's fair to say that when we talk about decrease in axillary surgery with neoadjuvant chemotherapy, this concept is primarily applicable to patients with operable breast cancer. Clinical T1 to T3, clinical N0, clinical N1. There have been some patients with clinical N2 disease that were included in some of the studies that we'll discuss with you, but the majority of the patients fall into this category. Early data suggested that the feasibility and accuracy of sentinel lymph node biopsy after neoadjuvant chemotherapy is questionable for patients with locally advanced breast cancer, including locally advanced disease T4, clinical N2, and inflammatory breast cancer. Now, clinical N2 is actually an entity that gets confused nowadays, but technically clinical N2 disease means matted lymph nodes in the axilla. Sometimes now people look at the MRI or look at axillary ultrasound and they see 4 abnormal lymph nodes and they say, well, that patient has N2 disease. Well, technically that patient may have PN2 disease when he had surgery, but clinical N2 is reserved to matted lymph nodes. So that's the one I'm talking about. Now, as already was mentioned as well, the clinical assessment of the axilla before neoadjuvant chemotherapy has changed compared to the time of the studies of the BO4 and even the B18 trial, as I will discuss in a minute. So now ultrasound of the axilla with fine needle aspiration or core biopsy of indeterminate or suspicious nodes is becoming a standard, particularly for patients that are to receive or be considered for neoadjuvant chemotherapy. It's a simple and minimally invasive technique and can provide us with useful information. If the biopsy nodes are positive and you think that the patient needs an axillary dissection, you can avoid the sentinel lymph node biopsy and proceed with upfront surgery. Or if you choose to use neoadjuvant chemotherapy, this approach can demonstrate as direct chemosensitivity. If that lymph node that was positive before now becomes negative, it allows us the opportunity to mark this lymph node with a clip or other ways to then eventually remove it and target it after neoadjuvant chemotherapy. And although the sensitivity, as was mentioned, varies to some extent, from 47 to 90% in some of the early studies, the specificity is obviously pretty high, almost 100%. The sensitivity, though, is actually low when the metastasis in the lymph node is less than 5 millimeters, but actually increases to 93% if the metastasis is over 5 millimeters. So at least with an axillary ultrasound, you rule out clinically significant disease in the axillary nodes, but you may miss a few millimeters of disease, which is very subclinical. So how do we then apply this in clinical practice? How do we approach patients with clinical N0 disease that undergo neoadjuvant chemotherapy? There has been a lot of debate, and to some extent still today that debate continues, whether you should do the sentinel lymph node before or after neoadjuvant chemotherapy. And after many years of debate, I think we all now agree pretty much that doing it after provides more opportunity. More opportunity to downstage the disease, potentially de-escalate surgical therapy, and prove chemosensitivity. This approach, of course, can only be achieved with neoadjuvant chemotherapy where the lymph node is present. If lymph nodes are removed, you lose that opportunity. Now, the data suggests clearly that when you apply sentinel lymph node biopsy in that group of patients, there's no difference in the sentinel lymph node identification rate and no differences in the false negative rate when you compare that to upfront sentinel lymph node biopsy. And although the initial data was from small institutional series and some retrospective review of randomized trials, now we have solid data to support that this is the case. Recent meta-analysis that was published in 2016, actually, looking at 16 studies with 1,456 patients that are clinical N0 and underwent neoadjuvant chemotherapy, showed an identification rate, pool identification rate of 96%, and a false negative rate of 6%, which, as you remember from the B32 trial and the Milan trial, lower even than the 8.8 or 9.8% that we saw in these trials. And the conclusion was that sentinel lymph node biopsy is technically feasible and accurate for axillary staging in initially clinically non-negative breast cancer patients that undergo neoadjuvant chemotherapy. Now, is this clinically important? And of course, I think it is, because when you look at patients that had clinical N0 disease and they were candidates for neoadjuvant chemotherapy, those patients have higher rate of subclinical involvement of the axilla. These are data from the NSABP B18 trial, which randomized patients to surgery first and 4 cycles of adriamycin cyclophosphamide, or the reverse, neoadjuvant AEC times 4 and then surgery. And for patients where the surgeon by palpation thought that the axilla was clinically negative, 48% of the patients that underwent surgery first had subclinical involvement of the axilla. If you remember in the BO4 trial that was mentioned previously, 40% of the patients similar to that. So for patients that undergo neoadjuvant chemotherapy, there is significant burden of disease. And in the B18 trial, about 75% of the patients had tumors less than 5 centimeters. So it wasn't all locally advanced patients. There were large operable breast cancer patients. Now, of course, these numbers probably are lower today because of axillary ultrasound and weeding out the patients that have subclinical involvement, but also radiographic involvement of the nodes. But nevertheless, it makes the point that if you do it up front, you may be finding a lot more positive nodes than you expect. Now, then the next step is, how do we manage patients that present with positive axillary nodes? And when we do the axillary ultrasound, we see that the nodes are abnormal, of course, they're palpable, and then we biopsy them, and they're positive. And we put a clip in these nodes. How do we manage this patient? Is there a role for sentinel lymph node biopsy alone if after neoadjuvant chemotherapy these patients are downstaged and become clinically non-negative, and we apply the sentinel lymph node biopsy concept? So there have been, as you see here, let me go back. There have been 4 prospective studies that evaluated the role of sentinel lymph node biopsy. All the studies followed the sentinel lymph node biopsy with axillary lymph node dissection, even if the sentinel lymph node biopsy was negative. So the 1071, the Sentinel trial from Germany, the Canadian SNF-NAC trial, and the French GANIA-2 study. If you look at the false negative rate for all these 4 trials, you see that it varies between about 12 to 14%, with the exception of the Canadian trial that was a little bit lower, 8.4%. But in the Canadian trial, the sentinel nodes were also examined by immunohistochemistry, as opposed to the other 3 trials that they were not. And this probably identified more involvement of the sentinel lymph nodes, lowering the false negative rate. But consistently also in these 4 trials, we see that the number of removed sentinel nodes it was associated with the false negative rate. And when only 1 sentinel lymph node was removed, you can see that the false negative rates were 31.5%, 24%, 18%, and 19.3%. But if 2 or 3 sentinel nodes or more were removed, the false negative rates dropped to single digits, but yet 9, 7, 4.9, and 7.8%. This is, I submit to you, this is not a phenomenon that we see after neoadjuvant chemotherapy only. We noticed the same thing in the NSABP B32 trial, where the false negative rate was twice as much of the 9.8%. It was about 17% for patients that had 1 sentinel lymph node removed. It was averaged about 9% with 2, and then dropped to low single digits with 3, 4, or 5 sentinel lymph nodes. So that's something that actually in reality exists. But in reality also, we see here that in this group of patients, the false negative rate is somewhat higher than we expected. So why is that? That brings us the issue of the anatomic concern that I mentioned before, that maybe the lymph nodes, because they're involved with disease and then they scar, an alternate pathway takes over. On the other side, the biologic phenomenon appears not to be the case, because if that was the case, we would have seen higher false negative rates in clinical and 0 patients that had a negative sentinel lymph node. But this is an issue. So how are we going to deal with this? Well, first of all, before I go to that, there has been also another meta-analysis that took all this information and other patients from retrospectively analyzed studies looking at sentinel lymph node biopsy after neoadjuvant chemotherapy patients with documented involvement of the axilla, and essentially demonstrated the false negative rate, not surprisingly, of 13%, which is exactly what these other studies have shown, and an identification rate a little bit lower than the upfront, 91%. But their conclusion was that sentinel lymph node biopsy after neoadjuvant chemotherapy in biopsy-proven node-positive patients results in a reasonably acceptable false negative rate and identification rate, making it a valid alternative to axillary lymph node dissection. However, they mentioned that a more refined patient selection and optimal techniques can further improve the false negative rate and identification rate in this patient population. So what is the next step? Well, An unplanned analysis from the Z1071, published by Judy Bowie, looked at the role of the clip in the node. If we can identify the clip and we removed it, would we affect the false negative rate? And when the clip was retrieved in the Sentinel node in this study, the false negative rate was only 6.8%. But if the clip was not identified in the Sentinel lymph node, but it was in the axillary dissection specimen, then the false negative rate was 19%. And the false negative rate was about average if no clip was placed or if the clip was not identified. So that was one of the first observations, that removing the clip from the axilla, the node that was involved before, will lower the false negative rate. And then the MD Anderson published their experience with the removing the clipped lymph node, removing the sentinel nodes, or doing both. So in a study, they actually did that. And what they noticed was that if they removed the sentinel lymph nodes and they counted only the sentinel lymph nodes, those that uptake the isotope and the blue dye, the false negative rate in patients, of course, with positive nodes before neoadjuvant chemotherapy was 10.1%. If actually they just removed the clip node and they only counted that, then the false negative rate was actually lower, was 4.2%. And if they called nodes that are sentinel nodes and the clip node, if they put those together, then the false negative rate was only 1.4%. And the reason for that was that in about 23% of the patients, the clip node was not a sentinel node. So another node was a sentinel node. So again, that brings us back to the anatomic concern that if the nodes are fully replaced with tumor, other lymph nodes probably will become sentinel lymph nodes, increasing your false negative rate. But if you take the positive node out, then the false negative rate drops substantially, which again then reassures us that the biological concern is not there. In other words, if the sentinel node becomes negative, the original node becomes negative, then the remaining nodes should be negative as well. And last year in San Antonio, we heard the results of the RESES trial. This was a prospective study where radioactive iodine seed was placed in the axilla before neoadjuvant chemotherapy, and then it was removed after neoadjuvant chemotherapy, along with sentinel lymph node biopsy. They included 227 patients. Out of those, 298 were successful. And then they focused on the patients that had residual disease in the axilla, which is 144 patients, and they performed an axillary dissection in these patients. And they defined non-inferiority of the false negative rate. If it was less, the upper bound of the false negative rate was 6.25, less than 6.25%, the upper bound of the confidence interval. That would have given them a non-inferiority margin for false negative rate corresponding to negative predictive value of 90%. So what they found was that the false negative rate was 3.47%, and this is again the targeted axillary dissection, which is the combination of the removal of the clip node and the sentinel lymph node biopsy. And the upper limit of the confidence intervals was 7.16, so they could not necessarily declare non-inferiority, but clearly the absolute number was fairly low. And when you compare that number to the MARI trial that they have reported previously from the same investigators, which is just removing the radioactively marked lymph node, the false negative rate was 7%. So clearly it appears to be lower than just removing the clip node. So this is the targeted dissection. So then we have a meta-analysis of this marked lymph node biopsy and targeted axillary dissection after neoadjuvant chemotherapy. And that, again, does not include the RESES trial because this was published in 2021. The RESES trial wasn't published at the time. So 9 studies, 366 patients that undergone marked lymph node biopsy, and 13 studies with targeted axillary dissection, the combination of marked lymph node biopsy plus sentinel lymph node biopsy. Overall, false negative rate 6.8% for the marked lymph node biopsy and dropping to 5.16 for targeted axillary dissection. I suspect that if we include the RESES trial, this number will be going even further down. And these false negative rates are significantly below the false negative rate of 13% of sentinel lymph node biopsy in this setting, as I showed you before, and clearly lower than the acceptable standard of about 10%, which is with upfront sentinel lymph node biopsy. Now, that rate is probably lower in experience sense today, probably 5%, but clearly we can achieve the same accuracy after neoadjuvant chemotherapy for patients that had a prior positive sentinel node. There are several techniques that you can use to mark the lymph node. You can use stainless steel markers, titanium, or polyglycolic acid, but in these cases, you have to then localize those and remove them, and I'll show you how we do it today. But also, you can put carbon or blank ink tattoo in up front, or radioactive iodine up front, or ferromagnetic seeds that you can then detect without a second procedure after neoadjuvant chemotherapy. In our practice, we use wireless techniques now to identify the clipped nodes. You can use the radioactive seeds, the SABCS probe. Sorry. Oops, I don't want to do that. I'm not sure what will happen now, but, oh, God, okay. Or the magnetic seeds, which is another way of localizing the clipped lymph node. So, when it comes to optimizing sentinel lymph node biopsy performance after neoadjuvant chemotherapy in patients with documented positive axillary nodes before neoadjuvant chemotherapy, appropriately select the candidates, T1 to T3 and 1, dual agent lymphatic mapping with isotope and blue dye, identification and removal of more than 2 nodes, clip placement in the positive lymph node with clip localization and retrieval, and consideration of performing immunohistochemistry in the sentinel node and consider axillary dissection even if the sentinel node has only N0 I+ disease. Now, with the application of clipped node removal, whether you need to have more than 2 sentinel nodes or 3 sentinel nodes becomes a question that we need to answer in future trials. Ultimately, though, axillary recurrence would be what we need to be focusing. And as Dr. Wong reported earlier for the upfront sentinel lymph node biopsy, we see now some data that support very low rates of axillary recurrence in patients that had either clinical N0, clinical N1 and 2 disease, or even up to clinical N3 disease, undergo neoadjuvant chemotherapy and then have sentinel lymph node biopsy alone. Admittedly, the follow-up is short in some of these studies and longer in others, but you can see that the rates barely are more than 2% in only one setting here and 0% in some others. So more follow-up, of course, is needed, but certainly it looks promising that the axillary recurrence will be low. On the other hand, if the sentinel node, after all this, is still positive, completion axillary dissection is the standard. And the reason for that is that we have higher incidence of non-sentinel lymph node involvement in this setting, even if the sentinel node is only involved with minimal disease, such as ITCs or micrometastasis. A study from Memorial Sloan Kettering that looked at 171 patients with positive sentinel lymph node biopsy after neoadjuvant chemotherapy that were followed then by an axillary dissection. 73% of those were clinically no positive, pathologically documented no positive, before neoadjuvant chemotherapy. And what they found was at least 1 or more additional non-sentinel nodes were positive in the axillary dissection in 17% of the patients with isolated tumor cells, although only 6 patients in this one, of course, in 64% of the patients with micrometastasis and 62% of patients with macrometastasis. So what they concluded from this is that low-volume sentinel lymph node disease after neoadjuvant chemotherapy is not an indication of low risk of non-sentinel lymph node metastasis, and an axillary dissection needs to happen outside of a clinical trial. Well, there is such a clinical trial, as you know, from the Alliance 11-202 trial that's still accruing patients, is close to be completed, and takes patients that have clinically positive nodes before, biopsy proven. They become clinically negative after neoadjuvant chemotherapy, but then they have sentinel lymph node biopsy that is positive, and they get randomized to completion axillary dissection or not, assuming, of course, that they will get comprehensive radiotherapy. So the results of this trial will be very important because they may eliminate the need for an axillary dissection even if the sentinel node remains positive after neoadjuvant chemotherapy. So in summary, advances in neoadjuvant chemotherapy have increased the rate of sterilization of subclinically or clinically involved axillary lymph nodes. Before neoadjuvant chemotherapy, axillary ultrasound with fine needle aspiration, core biopsy, and marking of suspicious lymph nodes should be considered. In clinical N0 patients, sentinel lymph node biopsy after neoadjuvant chemotherapy has similar performance characteristics as with upfront sentinel lymph node biopsy. In patients with documented positive nodes, clinical N1 who receive neoadjuvant chemotherapy, the false negative rate of sentinel lymph node biopsy is around 13%, but it can be decreased to less than 10% with removal of more than 2 sentinel nodes, dual agent mapping, and use of immunohistochemistry. Marking the involved lymph node, involved axillary lymph nodes before neoadjuvant chemotherapy and removal of the marked lymph node decreases the false negative rate to around 6% to 7%. And when you add sentinel lymph node biopsy to that procedure, which is a targeted axillary dissection, the false negative rate decreases to around 3 to 5%. Axillary recurrence rate with sentinel lymph node biopsy after neoadjuvant chemotherapy are favorable, but longer follow-up is needed. And finally, the need of completion axillary dissection in N1 patients who are found to be sentinel lymph node positive after neoadjuvant chemotherapy is currently being investigated in a randomized clinical trial. I thank you very much for your attention. Looking forward to the discussion.